This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 15, Toxicological Emergencies. And introduction. Out-of-hospital toxicology emergencies include the management of overdoses and poisonings. An overdose is an intake of a drug in sufficient quantities to cause harm to the body. A poison is any substance that irritates, damages, or impairs the activity of the body tissues. So toxicology here, toxicological treatment is based on the situation and it depends on the toxic agent. Drugs used in the treatment of the toxicological emergencies include emetics, which means they'll make you vomit. Drug antagonists, which generally block things. So drug antagonists will block the actual agent of the drug. Anticonvulsants, most of these, or all of these, will stop a seizure, and that it decreases your CNS activity. And then alkalizing agents, things like sodium bicarbonate. In the assessment, initial assessment is performed with ABCs in mind, airway, breathing, and circulation, and then we go into a secondary assessment. Take a good close look at the skin color and the breath odor. An example of this is if someone smelled like they were eating bitter almonds. This could lead you to that they could have got a hold of some cyanide. Skin color, cherry red skin, is indicative of things like carbon monoxide. History of the poisoning, always good in getting a good history of the poisoning. So what kind of substance, how much was involved, if you can get that information, when the poisoning occurred, any attempt at treating the poisoning, whether the poisoning was accidental or a suicidal gesture, and a significant medical history to the patient. Signs and symptoms should be continuously assessed for trending. That may help you get more clinical indication or actually find what kind of poisoning or what kind of poisoning agent was actually used. Common toxins here, there's ingested toxins, injected, absorbed, and inhaled. We're going to talk first here about ingested toxins. Ingested toxins include things like pills, like narcotics, aspirin, Tylenol, or acetaminophen, antidepressants, strong acids like toilet bowl cleaners, hydrochloric acid, strong alkaloids, drain cleaners, household bleach, ammonia, petroleum products, kerosene, gasoline, antifreeze, which is ethylene glycol, pesticides like strychnine, arsenic, and organophosphates. So first of all, we're going to talk about injected poisons here. Venoms, things from a snake or a spider or an actual insect, all can be venomous. Example of this, wasp stings can cause anaphylaxis or anything in between. Too many of them could actually poison the patient directly. The spider bite, most of them just cause, like if you brown recluse, would be necrosis of the actual tissue from the venom. The black widow spider will cause tetany or muscle spasm. Snakes like rattlesnakes, water moccasins, copperheads, like we see here in Oklahoma, all of these are pit vipers or have a hemotoxic poison. Drugs that we might see, heroin, cocaine, methamphetamine, all of these could be injected. Absorbed toxins. Absorbed toxins include things like cyanide and organophosphates. Management of absorbed poisonings is decontamination of the patient or decontamination of the skin. Dust off all the reactant chemicals. Wash liquid poisons if safe, and that would mean by mixing them with water. Administer specific antidote drugs per poison control. So if you don't know what an actual toxin does or an actual drug does, get on the phone with poison control and Figure out, tell them as much as you know, or what kind of toxin you think it is, and then have them look it up in their database. They're really good about giving you information that you might not have thought about. At IMSA and a few other services, poison control is considered as a medical control. So what that might do is that might get you an extension of treatment protocols that were maybe outside of your current treatment protocols. May give you some options. Inhaled toxins. Things like carbon monoxide, freon, glue, solvents like paint thinner, gasoline, or hydrocarbons, propellants such as fluorocarbons from aerosol cans, paint, cyanide, and organophosphates. Management of ingested poisons. Identify the toxin if possible. Contact poison control for direction. Healthcare professional access number in Oklahoma is going to be 1-800-222-1222. And this will vary according to the substance ingested. May be treated via emesis or antidotes if you have them on the truck. Consider an NG tube if they're safe, and poison control should be able to help you with that. And always protect the airway of ingested poisons. Vomiting should never be induced in anybody that is comatose or seizing, has a decreased level of consciousness. In a pregnant patient, has ingested a corrosive, has ingested petroleum products like gasoline, kerosenes, or anything like that, hydrocarbons, iodines, silver nitrate, cyanide, or strychnine. And the management of inhaled poisons, very nice and simply. Optimize their ventilation, put them on some high-flow oxygen, provide a non-rebreather mask. We can do it by, it increases almost to 99%. Bag valve mask device to assist ventilations as necessary with a reservoir end, or CPAP if they're holding their own airway. Provide specific antidotes to the patient when indicated. So if poison control tells you that you have this on the truck and you may use it as an antidote in this scenario, then by all means you have been given an order via medical control. If your protocols are not set up like that, a good thing to do then would be to run it by your medical control and see what they think. Management of inhaled poisons continued here. Cyanide, pretty rare, however highly dangerous, rapid onset, and has a high fatality rate when inhaled. Cyanide. Smell of bitter almonds, and that's not conclusive on that. What I mean is some people say it smells like bitter almonds, some people say no it doesn't. So it's not 100% conclusive if you smell bitter almonds that you're smelling cyanide. 3-step treatment plan, which would be amyl nitrate, followed by sodium nitrite, followed by sodium thiosulfate. Now, one of the things that we generally do is whenever we apply the antidote, is the antidote itself generally changes the poison to a lesser poison so that the body can eliminate it easier. And that's kind of what we do here, methemoglobin, and we'll talk about that here in just a little bit. Management of inhaled poisons, organophosphates, and this would be things like carbamates or pesticides, major component of many insecticides. Symptoms include signs of acetylcholine overload, nausea, sludge, nausea, profuse sweating, epigastric and substernal tightness, abdominal cramps, profuse salivation, muscular twitching. It can produce seizures, respiratory arrest. Pharmacological treatment includes atropine, and atropine in this case is the actual symptom solver. And then pralidoxime or 2-PAM chloride is the actual antidote. The 2-PAM chloride starts acetylcholinesterase working again, and that's the problem in acetylcholine overload, is there's no acetylcholinesterase to gobble up the leftovers, so we just get total 100% reinforcement. The 2-PAM chloride restores acetylcholine, and that removes the excess, restores acetylcholinesterase, my apologies, and that gobbles up the excess acetylcholine. And the atropine is an anticholinergic or an anti-parasympathetic or an anti-acetylcholine drug, so it solves all of our symptoms for us. Starting in the antidotes on the drugs, acetylcysteine, activated charcoal, amyl nitrate, these are by alphabet, atropine, diazepam, flumazenil, hydroxycobalamin, my apologies, Narcan or naloxone, nitroglycerin, oxygen, phentolamine, pralidoxime, sodium bicarbonate, sodium nitrite, and sodium thiosulfate are the drugs that we're going to talk about here, one at a time. So acetylcysteine or Antidote or Mucomist, and what this does is what acetaminophen does is it throws you into liver failure. So what this does is this encourages the mucoid secretions of the liver to increase, and it's kind of protective to the liver. So it acts on a sulfonyl group donor to restore liver glutathione. May also scavenge free radicals to prevent delayed hepatotoxicity as antioxidant. Encourages sulfonation pathway of metabolism for acetaminophen. Very simply, this is kind of protective if we get the antidote on board quick enough so that the patients have a good shot at not going into liver failure. Dosing, and this is a general knowledge drug, which we only need to know the mechanism of action and the name, and the trade name, generic and trade. Adults and pediatrics by mouth, 140 milligrams per kilogram initially, then 70 milligrams per kilogram every 4 hours for 17 additional doses. Adult and pediatric IV loading dose, 150 milligrams per kilogram over 10 minutes. Maintenance dose of 50 milligrams per kilogram over 4 hours. Contraindication if you're hypersensitive to it, and pharmacokinetics on this are unknown. No onset, peak, and duration. Activated charcoal, primary care drug. Activated charcoal is generic, and the trade is Acetylcysteine. I'll give you the Barney version of this. We'll read through it anyway. But activated charcoal is a fine black powder that absorbs many drugs and chemicals. It acts by absorbing toxic substances, thereby inhibiting the GI absorption, intrahepatic circulation, and thus bioavailability. It has a tremendous surface area, allowing for large amounts of absorption. The combined complex formed by the absorption process is secreted from the body in feces. It is a general-purpose emergency antidote in the treatment of poisonings by most drugs and chemicals. Tylenol, aspirin, atropine, barbiturates, DIG, dilantin or phenytoin, propoxyphene, strychnine, tricyclics, among many others. The activated charcoal gets into the small intestine, and it pretty much coats and soothes and relieves and does not allow for the drug to be absorbed in the small intestine, and allows for fecal elimination of it. So for adult dose, 30 to 100 grams PO. Pediatric infant, less than a year, 1 gram per kilogram PO. And children, 1 to 12, 1 to 2 grams per kilogram PO. Contraindicated in treatment of poisonings by cyanide, mineral acids, caustic alkalis, organic sulfins, iron, ethanol, and methanol. Pharmacokinetics on sets immediate, duration, and half-life are unknown. That would depend on your elimination. Cyanide poisoning. This is a quick overview of how some of this works. What cyanide does, and the Barney version is, it causes cellular bankruptcy. So it stops the mitochondria through cytochrome A3 from getting oxygen and being able to utilize oxygen well. So without oxygen, you go in an anaerobic state of metabolism, there's no energy. So our job here is to bind up the cyanide or change it into another poison so we can eliminate it easier and it's not as toxic to the body. Which brings us to this one, which is amyl nitrate. Amyl nitrate converts hemoglobin into methemoglobin, and that would be a lesser poison. Methemoglobin reacts with cyanide and chemically binds it, which prevents it from having any toxic effect, and then they'll eliminate it from the body. Adult dose, 1 to 2 ampules crushed, inhaled for 15 to 30 seconds. And this is an inhalant. It looks similar to an ammonia inhalant, but it's amyl nitrate. Nitrite, my apologies. Pediatric dose, 1 ampule crushed, inhaled for 15 to 30 seconds. Until sodium nitrite is prepared for administration. Every 5 minutes until the patient is conscious. Then repeat at longer intervals for the next 24 hours. Contraindications, none in cyanide poisoning. Onset, 10 to 30 seconds. Duration, 35 minutes. And peaks in about 3 minutes. Organophosphate. So, this is the green here. This is normal. So acetylcholine is released, and what we get on the postsynaptic side here is it picks up this information and then continues whatever action potential or whatever the neurotransmitter was signaling. Alright, so acetylcholinesterase stops the signaling process, which means whatever is left over after it binds with these sections here. If there's still some acetylcholine in the synaptic cleft, what acetylcholinesterase does is binds it up to where it stops the signaling. Organophosphates inhibit acetylcholinesterase. So again, what we get here is just continuous signaling again and again and again. So very simply, in an organophosphate poisoning, we're going to need two things. And this is just like chemical nerve agent. One of the things we're going to need is 2-PAM chloride. And what 2-PAM chloride does is it liberates acetylcholinesterase from organophosphate poisoning. So then we have all of our acetylcholinesterase again in this area, and we don't over-signal. Atropine, it's a primary care drug. Generic is atropine, and the trained is atropine as well. Mechanism of action: atropine blocks the action of acetylcholine on receptors in the AV and SA nodes in the heart. Stimulation of the parasympathetic nerve fibers is blocked, resulting in an enhancement of the sinus nodes automaticity, atrioventricular conduction, increased heart rate, and increased cardiac output. So if we're looking at the sympathetic parasympathetic nervous system and looking at it as a way to maintain homeostasis, what atropine does is it blocks the parasympathetic nervous system and it leaves a sympathetic dominance, which any catecholamine that you had in play at that point would do what it exactly to the cellular environment what it's asked to do, which is make things be harder, faster, stronger. Adult dose of atropine, 0.5 to 1 milligram, or 0.04 milligrams per kilogram. Some experts suggest 2 to 2.5 times the IV dose if we have to go down the tube. Pediatric dose, 0.02 milligrams per kilogram, IVIO, every 5 minutes, 2 to 3 doses. Contraindication: hypersensitivity to atropine, any kind of second or third degree AV block. Pharmacokinetics on this is onset immediate, duration is about 4 hours, and it is eliminated in the urine. Diazepam. Diazepam is a GABA agonist. Benzodiazepine, whose exact mechanism is unknown, but many believe it appears to be both at the limbic and subcortical levels. It is principally used for its anticonvulsant properties and suppresses the spread of seizure activity through motor cortex of the brain. It does not appear to abolish abnormal electrical discharge focus. It is also used as a sedative in the management of stress, anxiety, and to treat the withdrawal symptoms of alcohol. Diazepam is an effective skeletal muscle relaxant, making it an effective adjunct in managing orthopedic injuries. It is also useful as a premedication for minor surgeries and cardioversion because it induces amnesia. If you're being shocked by a defibrillator, I will assure you, you do not want to remember it, which diminishes the patient's recall of the actual procedure. The adult dose of this, and the generic on this is diazepam, the trade name is Valium. Adult dose on this for seizures of status epilepticus, 5 to 10 milligrams slow IV bolus. That can be repeated every 5 to 10 minutes as needed for a total of 30 milligrams. Now, most of our protocols do not take a large dose like that 30 milligrams and apply it. We generally have a cap of about 10 milligrams that we'll give during diazepam. You can knock out the respiratory drive with this medication, so be careful with that. May be administered IM if you can't obtain an IV. 5 to 10 milligrams for skeletal muscle relaxant, slow IV bolus or IM. Elderly or debilitated, skeletal muscle relaxant, 2 to 5 milligrams slow IV push or IM. Pediatric dosing, greater than 5 years, 1 milligram. IV or IM every 2 to 5 minutes for a total of 10. Less than 5 years, now that's a lot of Valium as well. Anything over 5, and you should be considering that you're probably going to knock out the respiratory drive. Less than 5 years, 0.2 to 0.5 milligrams slow IV bolus, or IM, every 2 to 5 minutes for a maximum dose of 5 milligrams. Your goal in this is whenever they're seizing, they can't really breathe well. So if you think the hypoxia is there and you're monitoring that and they're seizing, please eliminate the seizure. Just be prepared if you get high doses of diazepam on board to pretty much, you're going to have to control their airway afterwards. Contraindication, hypersensitivity to diazepam, benzodiazepines, or propylene glycol, pre-existing CNS depression, or acute narrow-angle glaucoma. Pharmacokinetics, onset 1 to 5 minutes, duration 15 to 60 minutes, and is excreted in the urine. Flumazenil, general knowledge. Generic on this is Flumazenil, and the trade's Romazicon. Mechanism of action, this antagonizes the effects of benzodiazepines. So our Valium, our Versed, all of them are essentially benzos. And what this does is it antagonizes them or binds them up. Adult dose is 0.2 milligrams IV over 30 seconds. Additional doses of 0.5 milligrams may be given at 1 minute intervals. Maximum total dose of 3 milligrams. Pediatric dose of 0.01 milligram per kilogram. Maximum dose of 0.2 over 30 seconds. Maximum cumulative dose of 1 milligram. Contraindications, hypersensitivity to flumazenil or benzodiazepines. Patients receiving benzos for life-threatening medical disorders such as status epilepticus or increased intracranial pressure. Serious cyclic antidepressant overdose because of the risk of seizures and arrhythmias. Pharmacokinetics, onset is rapid, and the duration is 30 to 60 minutes. First order of elimination. Hydroxycobalamin. The generic is hydroxycobalamin, and the trade name on this, which is a lot easier to say, is Cyanokit. Mechanism of action. This is vitamin B12 with a hydroxyl group complex to cobalt, which can displace cyanide, resulting in cyanocobalamin that is renally excreted. So this binds to the cyanide and allows for its elimination without its toxic side effects. In the adult dose, 5 grams IV piggyback over 15 minutes. Now this is a drip. Pediatric dose of 70 milligrams per kilogram IV piggyback over 15 minutes. Contraindications, none in suspected cyanide toxicity. Pharmacokinetics, half-life of 26 to 31 hours and 1 to 35 days. Narcan, or naloxone, a primary care drug. This binds up, this is an antagonist of narcotics, more specifically opiates. Combines with narcotic receptors and blocks or reverses the action of narcotic analgesics, including CNS and respiratory depression. Adult dose in this is 0.4 to 2 milligrams by slow IV bolus, IM/ET sub-Q. Can be given intranasally at 2 milligrams as well. Pediatric dose less than 5 years is 0.1 milligram IV/ET/IM sub-Q, or may be repeated every 2 to 3 minutes as necessary. Pediatric greater than 5 years, 2 milligrams IV/ET/IM or sub-Q. Sub-Q would be a slower route. Generally, we want this on board because they're in respiratory depression or respiratory arrest. Contraindications, any hypersensitivity to the drug. Pharmacokinetics, onset 1 to 2 minutes and duration 1 to 4 hours, and this is excreted in the urine. Nitroglycerin. Trade name on this is Nitrobid or Nitrolingual. Nitroglycerin is an organic nitrate with potent vasodilator and anti-anginal, antidysrhythmic. This is the same one we use for chest pain or acute coronary syndromes, and the adult doses are the same. 0.3 to 0.4 by tablet, 0.4 milligrams by sublingual spray. We can give an infusion. We generally start off the infusion at 10 mics per minute and increase by 10 every 3 to 5 until we get them pain-free. 1 to 2 sprays of the nitrolingual spray. Please one spray at a time. Let it soak in and see what it does. Adult ointment 1 to 2 inches every 8 hours, up to 5 inches every 4 hours. And then there's transdermal patches as well. Contraindications: do not administer nitroglycerin to patients with a hypersensitivity to the drug, head trauma, hypotension, hypovolemia. Do not administer in patients in shock. Do not use it with patients with severe bradycardia or tachycardia. Nitro should not be administered to patient taking medications for erectile dysfunction either, because of the possible life-threatening hypotension. Pharmacokinetics: onset 1 to 3 minutes, and duration up to 30 minutes, and is excreted in the urine. This one should be quick. Oxygen. Trade name is Oxygen, and we have 21% of the atmosphere. So an example of this is if you had a person with carbon monoxide poisoning, we would want to increase the oxygen percentage. If they have locked down all of their hemoglobin, it's going to be a very hard fight. But if they haven't locked down, you should try to superload them to try to get as much oxygen on board as you possibly can. That way, what they can carry, they can easily, freely pick it up as it comes back. Phentolamine, this is the antidote. While we were I put this in as an antidote. This is the antidote for things like dopamine and levofed if they get in the extravascular space in your tissues. So let's say you didn't get an IV stick quite right, or your IV stick was leaky and you were dripping in dopamine or levofed. It would cause a direct alpha agonism on the tissues. So that would cause a vascular constriction. The patient could have necrotic tissue because of that. And what phentolamine or Oraverse does, causes hypotension by direct relaxation of the vascular smooth muscle by an alpha blockade. So this would block what the other medications that were in the tissues were trying to do. We can use it in hypertensive emergency in an adult, 5 to 15 milligrams IV/IM. Cocaine-induced vasospasms, adult 5 milligrams IV or IM. Pediatric doses are not recommended. Do not use in patients with coronary or cerebral atherosclerosis or in patients with renal impairment. Pharmacokinetics: onset's immediate, durations 30 to 45 minutes, and this medicine is excreted in the urine. Pralidoxime, and this is 2-PAM chloride, protopam, reactivates cholinesterase that has been inactivated by organophosphate poisoning or anticholinesterase overdose. Results in reversal of respiratory paralysis and paralysis of the skeletal muscle. And organophosphates, 1 to 2 grams by IV infusion over 30 to 60 minutes after atropine administration. In the pediatrics, 20 to 40 milligrams per kilogram by IV infusion over 30 to 60 minutes. Doses may be repeated in 1 hour if muscle paralysis is still present. Contraindication: any hypersensitivity to the drug, and do not administer to patients who have been poisoned by inorganic phosphates. Pharmacokinetics on this are going to be onset in 5 to 15 minutes. Sodium bicarbonate, this is an alkalizer essentially. Generic on this is sodium bicarb, and so is a trait. Short-acting, potent, systemic antacid. Given IV, it immediately raises the pH of the blood plasma by buffering excess hydrogen ions. This is essentially going to pick up extra hydrogen ions and make H2CO3. And then our body's going to break that down to H2O plus CO2. We eliminate the CO2. Water goes to the kidneys. Elimination of the acid. 1 milliequivalent per kilogram on both pediatric and adult. Contraindication: none when used in documented metabolic acidosis. This is going to be an antidote for tricyclic antidepressants. Pharmacokinetics: onsets in 15 minutes, duration 1 to 2 hours, and is excreted in the urine. Sodium nitrite. This is part of the old cyanide kit. This goes along with amyl nitrate. Amyl nitrite, sodium nitrite, and sodium thiosulfate all are a part of the old cyanide kit. Generic on this, sodium nitrite, trade sodium nitrite. Sodium nitrite reacts with hemoglobin to form methemoglobin, so this is what the amyl nitrate was doing as well. Methemoglobin reacts with cyanide, causing the cyanide to be chemically bound, prevents it from having any toxic effects. Subsequent administration of sodium thiosulfate produces thiocyanate, which is excreted in the urine, thereby detoxifying the body. Sodium nitrate degrades cyanide in cases of cyanide poisoning. Adult dose on this, 300 milligrams. Administer either by IV bolus over 5 minutes or by diluting 300 milligrams in 50 to 100 mils of normal saline and infusing slowly. Monitor the blood pressure closely. Pediatric dosing, 0.15 to 0.33 mils per kilogram by slow IV bolus. Contraindications are none. Pharmacokinetics, thiocyanate in 2 to 7 days. Sodium thiosulfate, also general knowledge. Generic and trade are the same, sodium thiosulfate. Sodium thiosulfate converts cyanide to a less toxic thiocyanate. The thiocyanate is then excreted in the urine and the body is detoxified. Again, are we seeing a picture here? All of these toxicological agents are changing the poisons or the byproducts of the poison in the body to a less serious poison that the body can eliminate. Adult dose on this, 12.5 grams by slow IV bolus, 150 ml ampule of a 25% solution. Pediatric dose, 1.65 mils per kilogram of a 25% solution by slow IV bolus. Contraindications are none. Pharmacokinetics, thiocyanate in 2 to 7 days. Whew, lots of big words. Conclusion. Patients with poisoning or overdose emergencies should be treated symptomatically. Out-of-hospital management should include the following: management of the ABCs, administration of oxygen, establishment of an IV line, placing the patient on a cardiac monitor. If we can get ahead of the poison by contacting poison control, then we should do that. We carry a lot of antidotes in our drug regimens that we have. Management of the poison emergencies include identifying of the poison, attempting to slow or stop the absorption process, and administering the antidote if we have it. Care should always be guided by expert advice, and that means call poison control. They know more about that poison than any other person. References for this were taken from Beck Pharmacology for EMS Providers, Delmar Learning, and Bledsoe's Pre-Hospital Emergency Pharmacology, 7th edition by Prentice Hall. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.